Hello everyone. Today we are going to talk about the displacement of the uterus. So we can say if we talk about the normal uterus position, so that is the anteversion and the anteflexion. Okay, so this is the normal position of the uterus. So when the uterus is changing the position, so that is called as the displacement of the uterus. So let's talk about in the detail. So this condition mostly comes in the gynecological nursing. So first of all, we'll be talking about the introduction. So the uterus is not in a fixed position in the pelvis. So if we talk about the pelvis, so in the pelvis, the uterus will be situated, right? So normal position, as I said, anteversion and the anteflexion has to be there. So we can say here the position of the uterus is that is not fixed enough. So due to that, what happens? Displacement will be there. So minor variation in the position occur with the changes in posture, with the straining and with full bladder or the rectum. So we can say the minor variation used to come inside the uterus, inside the position of the uterus, when the bladder is full, when the rectum is full, when even though mother is standing position, when the woman is in a lying position. So according to the posture, the position of the uterus will be changing a little bit. So minor variation, that is a normal, but more variation is coming, so that is considered as a displacement. So we can say here why they have talked about the bladder and the rectum. So if we talk about the normal anatomy of the uterus, so we can say the uterus front side is there, so that is the bladder is situated, and the back side, the rectum is there. So whenever the rectum and the bladder is full, okay, so what happens? Due to that pressure also will be coming over that and the position will be changing with that. So when the uterus is rest habitually in the position beyond the normal limit of the normal variation, it is called as a displacement. So we can say normal minor variation, that is okay, but beyond the normal variation, if it is resting habitually, so we can say the habitual, the uterus has become the habituate to rest forward, or the rest lean forward, otherwise the backward, otherwise it will come to the descent down. Okay, so if this kind of thing is happening, so that is considered as a displacement of the uterus. So here the commonly occurring displaced uterus are or displaced position are. So there are the mainly three positions, or the three disease comes inside the displacement. So in that, first one is a retroversion, then second one is a prolapse, and third one is the inversion of the uterus. So we can say whenever the uterus is changing the position due to any other reasons, okay, habitually if it is resting forward or backward, or it is coming down. So this kind of condition will be there: retroversion, prolapse of the uterus, and the inversion of the uterus. So each one we are going to talk about. So as you can see in this condition also, so this is, as you can see in this picture, okay, so this is the normal position. As you can see, the uterus is between, here the bladder is there and the rectum is there. So as you can see, when the uterus and rectum, they are both filled, okay, so what happens? So that pressure will be coming and this position will be changing. So that is a normal thing. But when it is resting backward, as you can see, so that is known as a retroversion. When it is retroverted, then after the retroflexed, completely it is resting backward. So that is a retroflexed. Why? Because that is flexing backward. So that's why. Then after the anteverted. So as you can see, the completely that is leaning forward to the bladder side. So this is how the retroversion of the uterus will be there. So let's talk about the retroversion of the uterus in detail. Okay. So here, retroversion is a turning backward of the uterus with the long axis of the corpus and the cervix in the line, in the whole organ turned backward in relation to the long axis of the birth canal. So here what is happening? Here the uterus will be turning backward. So as you can see, retroversion, retroflexion, and the anteverted. So here what is happening? The whole uterus is there. If we talk about the normal uterus size and shape, so we can say this is the part of the fundus, this is the body, and this is the part of the cervix. Okay, so this is how the uterus is divided. So here what they are saying, the corpus, so corpus, we can say the body, that is also known as a corpus. So here the turning backward of the uterus with the long axis of the corpus. So we can say the uterus is there, that will be turning backward. So corpus will be there, the long axis of the corpus is there, that will be same as it will be, but only fundus part is that will be leaning forward or leaning backward. So retroflexion is a bending backward of the corpus on the cervix at the level of the internal os. Here what is happening? In the retroflexion we are talking about, okay. So in the retroflexion, the uterus is there, the fundus part is there, that will be bending backward of the corpus. It means that fundus part and the corpus part, that both the things are bending backward, okay. And what is happening, that is the level of the internal os. So where the internal os will be there, so here where the cervix part is there, internal os and the external os will be there. So we can see this whole part will be backward, okay. So that is known as a retroflexion. Then after, the two conditions are usually present together are referred as a retroversion and the retroflexion or the retrodisplacement. So here simultaneously that is also we can say associated with the other condition also. So that is a retroversion and the retroflexion, otherwise you can say the retrodisplacement. So here the degree of displacement has been given. So in that first degree, second degree and the third degree is there. So in that first degree, the fundus is vertical and pointing towards the sacral promontory. So we can say sacral promontory are there, that will be the on the behind part, okay. So we can say the rectum and these things are there, that side the sacral promontory will be there, and the front part we can say the symphysis pubis will be there, okay. So here what they are saying, the fundus is the one. So we can say the uterus is there, so we can say the top part, that is known as a fundus. So fundus is in a vertical position and that the fundus is directly pointing towards the sacral promontory. So that is known as a first degree. Then after we will talk about the second degree. So the fundus lie in the sacro-hollow but not below the internal os. It means that here the fundus part is that will be backward, okay. But where the sacral hollows are there, we can say the sacral vertebra are there they will be pointing towards, okay. And here, but what happens, not below the internal os. It means that this portion will be as it is, only this part will be bending backward, okay. So we can say fundus part also and the little part of the corpus also, and this all the part will be nearby to the sacral sacral vertebra. Then after third degree, that is known as a fundus lie below the level of the internal os. It means what happens, here the fundus and the corpus, that part will be bending completely downward at the level of the internal os. So we can say this is the degrees of the displacement. First degree, what happens in that, the fundus is that directly pointing towards the sacral promontory. The second degree, in that what happens, the fundus is there, that will be lying or that will be bending backward nearby the sacral vertebra, otherwise the sacral hollow, but not below the internal os. But in the third degree, what is happening, the fundus and this we can say the corpus or the body part is that will be coming at the level of the internal os. So this is how it is known as a prolapse, or we can say the degree of the displacement. Now we'll be talking about the causes. So first of all, in that, developmental defect. So the phenile position of the uterus is retained. There is a lack of the uterine muscle tone and the condition is associated with the short vagina, which is shallow the anterior vaginal fornix. So we can say why this condition will happen. So we can say developmental defect. So in that, what is it has written, there is a lack of the uterine muscle tone. So here if I say how the uterus is being there in the position, so we can say surrounding structures are there of the uterus, and the muscles are there, pelvic muscles are there. So this everything is going to give the support for the uterus to stay in the position. But when the uterine muscles is weak or the pelvic floor muscles is weak, so what happens, the position of the uterus is that is also going to be changed. So here it has written, there is a lack of the uterine muscle tone and the condition is associated with this. So we can say the muscle tone are there of the uterus, that is a lack. So we can say the weakness will be there inside the muscle. So what happens, that will not be able to hold the uterus in the position. Then after, associated with other condition also will be there, that is a short vagina. So we can say the vaginal canal is that has been shortened. So due to that also what happens, the uterus is that will be backward, the bending backward will be there. Then after the anterior vaginal fornix, so we can see the vaginal wall is that will the vaginal wall that is known as a anterior vaginal fornix, otherwise the posterior vaginal fornix. So we can say due to that also, if the vaginal canal is shortened, then what happens, the vaginal fornix and the vaginal wall are that is also going to be shortened. So that is the developmental defect. So from the birth, this kind of defect is there. Then after the peripheral, so due to the stretch ligament caused by the childbirth. So we can say due to the excessive stretching, or we can say the overstretching of the muscles. So due to that also, so I'll give you one example. So when the mother is getting pregnancy, when the mother is pregnant for the first time, so we can see all the physiological changes will be coming inside the body of the mother. Okay, so we can say the uterus and the other this bladder and everything, and the abdominal muscle, pelvic muscles, everything is going to have the changes. Okay, so we can say when the pregnancy is there, and due to this physiological changes, once the muscle tone has been relaxed, or we can say the muscle tone has been lost, so that will be never regained. It means that we can say the strength of the muscles are there, that will be weakened once, so that will be never come again as same as the non-pregnant state. Okay, so here what is happening, the mother has lost the tone of the muscle. So due to that what happened, the relax of the uterus is that also will be relaxed, and the perineum and everything will be relaxed. So that is the normal physiology we are talking about. But here we are talking about the overstretching. So overstretching will be there when the precipitate labor is there, when the obstructed labor is there, when the multiple pregnancy is there, then after when the polyhydramnios is there. So I'll say the little brief regarding this. So first one, we have talked about the multiple pregnancy. Okay, so multiple pregnancy, what does it mean? So when the twins pregnancy, as you have heard, so when the uterus is there, that is if the uterus is okay, if the single baby is there, okay, so in that they will be able to give the complete nutrition, complete space for the baby. But when the uterus have the 2 or 3 baby or 4 baby, so we can say the uterus area, the surface area is there, that is going to be expanded. Okay, so we can say the overstretching of the muscles will be there. So what happens, the muscle has loosened their strength and everything, so that is not going to be revert back. Okay, then after the second condition is a polyhydramnios. So in the polyhydramnios, what happens, when the amniotic fluid is more than the 2000 ml. So we can say when the amniotic fluid is more than 2 liter. So what happens, overstretching of the muscles will be there. So due to that also, the surface area and the muscle tone, everything will be weakened. Then after another condition is a precipitate labor. So in precipitate labor also, hyperactivity of the muscles will be there. So hyperactivity, it means the way the muscle has to work, in that they will be working double and triple. So what happens, they will be losing their this, we can say, the strength and tone, everything they will be losing. Then after the obstructed labor, in obstructed labor what happens, if we talk about the normal normal labor duration, okay, so that will be about the 12 to 15 hours. Okay, so within that period of time the delivery will be there. But in obstructed labor what happens, more than 20 hours if the labor process is being last, so that is known as the obstructed labor or the prolonged labor. Prolonged labor, that is known as when the this hour of the normal delivery are that is more than 20 hours. Okay, that is known as the prolonged labor. So you can imagine the mother is on the labor table and she is doing the bearing down effect and the uterine contraction, everything is coming. Okay, and she is bearing this pain and everything for more than 20 hours. So we can say the muscles of the uterus is there, that is also going to be have the exhaustion. Why? Because they are working more than their limits. So that's why what happens, they will be losing their we can say they will be losing their tone, and the, we can say, the muscle strength and everything will be lost. Then after the obstructed labor, in obstructed labor what happens, most probably two kind of condition will be there. One is when the baby is large and the vaginal canal is a little bit narrow. It means we can say the birth canal is adequate but baby is large. So we can say the fault in the passenger, fault in the we can say power, and the fault. So this kind of things are there. So that is known as obstructed labor. Okay, so we can say when the baby is more than 4 kg, so what happens, the baby is not capable to pass from that birth canal. Okay, if the normal delivery is happening for the 4 kg kind of baby, so what happens, there is a chances to happen the laceration, otherwise the perineal tear will be there. Okay, otherwise another thing is there, we can say the adequate baby is there. So we can say the birth weight of the baby is like the 3 kg or lesser than that, or 2.5 kg. So that baby is and we can say the vaginal canal or the pelvic cavity is lesser, so contracted pelvis is there and the baby is enough. So we can say this is also thing from where the baby won't be able to pass. So this kind of condition also going to have a more complication over the uterus. Okay, so due to that also overstretching of the muscles will be there. Then after the microsomia, so microsomia, it means when the birth weight is more than the like 4 kg or 3.5 kg. Then after the, we can say the hydrocephalus. So due to that also obstructed labor and everything will be there. So we can say this condition, whatever we talked about, that everything is going to have the more stress over the muscles, and due to that the tone of the muscles and the strength, everything will be lost. Then after the prolapse caused by the traction following the cystocele. Now what is the meaning of the cystocele? So we can say the bladder is there, that is a full, and that is a bulging inside the, or bulging into the vaginal canal. So due to that also we can see the vaginal canal and everything is there, that is going to be disturbed. Then after the fibroid tumor in the anterior or the posterior wall of the uterus produces the heaviness, making it the falling behind. So we can see when the uterus have the fibroid, okay, so we can say this is the uterus and the all the layer, 3 layers are there, myometrium, endometrium and the parometrium, right? So any of them have the fibrosis. So what happens, heaviness will be there, and due to that the uterus is that will be leaning backward, or that will because of that it will fall behind. Then after the pelvic adhesion, so adhesion either inflammatory, operative or due to the endometritis pull the uterus posteriorly. So we can say if the uterus have any infection, or we can say the pelvic inflammatory diseases are there. So what happens, due to that more heaviness will be there, and because of that will be leaning backward. Why? Because in the infection and the inflammation, what happens, all the muscle are there, muscle or the cells and the tissue are there, that will be dead enough. Okay, if they are not working properly, so what happens, that muscles are there, that is not going to hold this uterus in the position. So that's why that will go to the posterior side. Then after the operative, so we can say before any operation has been done, any repairment has been done, or before uterus rupture was there and they have done the repairment inside that, okay, or they have taken the suturing. So due to that also that muscles will be not the adequacy will be not there, they will be not working properly, or we can say the tone of the muscles are that will be also lost. So due to that also that will be fall behind. Then after the because of otherwise the endometritis also, so we can say when the endometrium layer are there, that will have the necrosis or any inflammation is there. So due to that also the heaviness will be created, and that will be because of that the uterus will be going to the posterior side. Then after the incidence, so what will be the incidence for this? So the condition is seen about the 15 to 20% of the normal woman. So here we can say this kind of condition will be seen for the 15 to 20% inside the woman. Then after, what kind of sign and symptoms will be there? So chronic premenstrual pelvic pain due to the varicositis in the broad ligament produced by the kinks. So we can see here what will be there. So broad ligaments. So what do you mean by that? So if you see the anatomy and the physiology of the uterus, so uterus is the one, and that will have the curtain-like ligaments. Okay, so that broad ligaments, that is known as a curtain-like ligaments. So that will be starting from the uterus front part to the cervix side. Okay, so that ligament are there, that is also going to help they are going to give the support the uterus to stay in the position. So when any injury comes to this broad ligaments, okay, or any surgery has been done, so due to that also what happens, the weakness will be there over the ligaments. Okay, plus here it has written that chronic premenstrual pelvic pain will be there. Why? Because here the uterus has been gone backward. So what happens, whenever the this menstrual cycle is there, that time the pelvic pain will be there. Then after dyspareunia, due to the direct thrust by the penis against the retroflex uterus or the prolapse ovaries lying in the pouch of Douglas. So we can say dyspareunia, it means that during the sexual activity the pain will be there. So here what is happening actually, if the third degree prolapse or third degree displacement is there, so in that third degree what is happening, the fundus and the body part is there of the uterus, that will be coming to the level of the internal os. Okay, and if this kind of thing, if the mother is suffering from the displacement or the retroversion, and they are going to have the sexual activity, so what happens, direct penetration of the penis, that is also going to cause the more pain. Okay, and sometimes what happens, this displacement has happened, so due to that what happened, the uterus, we can say the uterus is there, and on the both the side, on the either side of the uterus, the fallopian tube is there, and attached with the this ovaries will be there. Okay, if the uterus is going backward, then of course the fallopian tube and we can say the ovaries, that everything will be coming to the pouch of Douglas. Now where is the pouch of Douglas? So we can say the uterus and the rectum, between that empty space is that is the space is known as a pouch of Douglas. So there we can say the ovaries will be coming, so due to that also more pain will be there during the sexual activity. Then after infertility, as the external os is away from the seminal pool at the posterior fornix during the coitus, or it may be occulted by the anterior vaginal wall. So here we can say if we want to have the fertilization, so for the fertilization we can say the supravaginal region is there the deposition of sperm will be there, and from there the sperm will be traveling to the cervical part, body part, then after directly from the fundus that will be going to the fallopian tube. Okay, so that is a normal physiology of the fertilization. But here what is happening, this whole uterus is that is going backward, so we can say that there is a chances to happen the infertility also. Why? Because occlusion will be coming, we can say due to occlusion, or we can say anything is coming and that going backward, so what happens, very easily sperm won't be able to travel from the supravaginal region to the fallopian tube, or we can say the ampullary part of the fallopian tube are there the sperm won't be able to travel. So due to that also there is a chances to happen the infertility, so we can say the couple will be not able to conceive the pregnancy also. Then after, on the bimanual examination, body of uterus is felt in the posterior fornix and cervix is directed upward. So here what happens, if you go for the examination of the mother, so that time if you go for the PV examination also, what happens, the cervix are that will be going to the upward. Why? Because the fundus and the cervical fundus and the body part of the uterus is that has gone posteriorly. So what happens, eventually this we can say the cervical part or the internal os and the external os are there, that will be gone to the higher. Then after, on the speculum examination, the cervix is viewed easily, the external os pointing forward. So if you go for the speculum, we can say this same speculum, or that if you do the examination by that, so by that also you will be able to see the cervix very easily. Why? Because that has gone a little bit upward, so that is by the speculum, because we can say the vaginal wall and everything we are going to retract properly, so very easily you will have the view of the cervix also.